Good to be here. Absolute pleasure. I'm going to use the mic. So it's been a great few talks, and it's quite inspiring. What I do is very simple. I'm just using some technology that already exists, putting it together. And the idea for the students in the room is think beyond what's normal, right? We were taught from a very young age in medicine and in a very young stage of our careers, just follow the standard conventional practice. And what I would say, and what Dr. Vocher has always allowed me to do, was think beyond, think big. It keeps me grounded somewhat, but think big. Because if you don't think beyond the confines of what is considered normal or what is considered standard, then there's no progress. And as you listen to speakers before me, progress requires thinking big. We've all had butt puckering experiences when AVMs rupturing on us, and there are opportunities in that experience to do better. There are opportunities to learn. There's opportunities to shake less. But you're right, we're human. To err is to be human, right? And so can we use technology to do better? We'll see. So the idea here is, what do we do in a situation where a person comes in? We've all heard in the news lately, the young guy is fused, he's not getting his medical bills paid for, he ends up murdering the CEO of United Healthcare. What type of person, and I don't know anything about him, what type of pain, what type of system failure, personal failure, psychological failure, medical failure had to have happened for that to be the recourse, that to be your answer? It's pretty devastating on many levels, not even the fact that someone was murdered, but of course someone was murdered, but how it got there, right? And the idea of fusing a joint, we do, both Dr. Vogt and I both do brain and spine, and we looked at the spine because the spine, there are certain things in the brain that we're very limited in looking at AI, and we're looking at brain-computer interfaces, but in the spine, there's this old standard that rods and screws are fancy and colorful and they look good and they solve problems. Truth of the matter is that no one really has tested that. No one knows that it's solving the problem long term. If anything, we've shown that it actually creates more problems long term. And yet, when you venture into the unknown, we are considered the heretics because we're doing something that's less proven than stuff that's already not proven. Make sense? So think about it for a second. How many people in the room, they're probably very young. How many people in the room have hip replacements? Knee replacements? Okay, wrong crowd. But there probably is someone in the crowd. I was hoping Bill, you'd say something now. I need it. You may. But everyone in the room has enough common sense to know that if you need a new hip, what do? Give you one, right? Do they fuse it? Do they lock it? Do they brace it? They put a big screw through it and you're walking like this? No, they give you a new hip. What about a knee? They lock your knee? No, they give you a new knee. So why is it that in the spine, when someone's spine is falling apart, they lock it in place and they fuse it together? Because it's the standard here for the last 40 years. Paid well? It's fun surgery? Patients don't do well long term. So the concept of artificial disc replacement or motion preservation, albeit not new, has not become commonplace. And I'm going to take it one step further. What I'm going to talk about is really heresy. So the idea of an artificial disc, you guys can see the screen. Does that cursor work? Can you see it?
Yes.
Okay, good. The idea of an artificial disc is let's restore motion to the shock absorber in the front of the spine. It's not new. It's been around in Europe for about 30 years. The concept's been around since the 60s, actually. Just they never worked. And they've been approved in the United States and being used for about 20 years. So the idea of motion preservation, again, I'm going to blast through this talk because I can talk forever on this one slide. But the idea of motion preservation, if you have a car, you're driving a car, and one of your shock absorbers is bad, what do you do? Not a trick question. You replace the shock. What happens if you decided to duct tape it and you don't replace the shock? You can drive, not so comfortable. You can drive. When's the other three shocks that are working normally? They're going to take on biomechanical stresses that are unnatural, right? Because the car is designed to have symmetric stresses, right? Wear and tear. So what we've shown is that when you fuse the spine together with rods and screws and you lock it in place, the rest of the spine starts to fall apart at an aggressive rate and a more accelerated rate. So the artificial disc, where we're replacing the disc, not new. Some people don't like it. Doesn't pay surgeons as well. There's all kinds of reasons why. But one of the biggest reasons why we can't do an artificial disc replacement in someone is because the facet joints in the back are not healthy enough to allow motion. The spine's more complicated than a shock absorber, right? You need three-dimensional motion for things to work. So the people who were getting artificial discs were young and healthy, for some reason had a bad disc, and they would have a good facet in the back, and it would work for some period of time. Until recently, replacing the joint in the back of the spine didn't exist. It now exists. And what we decided to do was start a trial and say, hey, I'm going to go through all this really fast. We don't care about this stuff. I'm going to say, hey, if someone who has a good clinical indication for an artificial disc but can't get it because they have bad facets in the back, discs in front, facets in the back, okay? But if someone has a good indication for an artificial facet, which we now have available, they can't get it because of the disc, because it requires front and back to work together. Why don't we put them together? That's all this was. So Dr. Vokshar and I got together and said, let's be bold. And we're the only ones in the world currently doing this. So we decided to take two technologies that have been used in Europe for over a decade, both of them, discs even longer, and let's say, let's give people a chance not to be that United Healthcare situation, not to have rods and screws, and let's look at motion preservation, not in 2 dimensions, but in 3 dimensions. 360 degrees from the front and the back. And this is what we did. We put in, they look like screws. I know they look like screws because they are screws, but they're not being used because they're anchoring the device in behind. That's a motion preservation device. And the disc in front. This, until Dr. Vokshar and I started doing it, had never been done before. And a lot of people think it's crazy. And what I can say is we now have, I don't know, 12, 13 patients over 18 months, and not a single one has failed. Still early. We don't know the answer. We just enrolled 3 more. But if this were to fail, I still confuse them. I still have backups. I still have options. But currently we have people with this concept of 360 degrees of motion preservation, would change the whole shock absorber, not just half of it, right? Would change the whole shock absorber. Let's give them a chance at motion preservation, because if this segment is moving naturally and needed to be replaced in the first place, the rest of the spine will move naturally, or as close to naturally as possible, with it, preserving long-term spine health. And that's the goal of what we're doing. And all I can say is, you know, these are patients who are 6 weeks, 3 months out, back to walking their dog in Santa Monica, back to doing martial arts. We have a fencing champion. We have 2 doctors who flew in to have this done. One's a windsurfer who's windsurfing, skiing. So will it work long term? We don't know. This is a case. This one's different. And I know it's hard to tell, but this one's a little bit different. Because in this case, this is what's called a grade 3 L5S1 spondylolisthesis. This has never been done before. Forget the trial. This has never been done before in the world. And this is actually currently in press and about to be public. And Dr. Vokshar and I were both in this case together, where we corrected someone who was 36 years old, who'd been told by 3 other surgeons that the only option was fusion. Correct. For this condition, where the spine is literally slipping off of itself, there were no other options available. He was having worsening back pain. His leg was falling asleep. He's 36. He stopped boxing, stopped walking his dogs, couldn't function. He is now 6 months out and was skiing and has a video of him doing kickboxing. And is the happiest 36-year-old I know. Do I know this is a panacea or a cure-all? We don't know that yet. It's too early. So the lessons here for the students in the room, don't be afraid to think beyond the norm. But if you're going to do it, you do it properly. We're doing it under the auspices of a formal trial. We have an entire team looking at the data. And we're very, very strict on the patients we include or exclude. That's about it. So think big. Technology is going to always move forward. There's all kinds of ways you can use the technology. The way it's meant to be used, other ways, and beyond. And that's it.